Okay, can you hear me?
Yep.
Excellent.
Trying to find a link for that thing on Friday.
What's that?
We got a homeopathic conference.
Oh, really?
Yeah.
Is that with the Canadian lady?
Yeah.
Parva? I think it's Parva. Okay. Is it a 1 day event?
It's 2 days.
Oh, okay. Okay. Just got off the phone with Dr. Burgess.
I'm making
He's,
you the co-host here, okay? Yeah,
yep.
what's he up to?
Same old, same old. He was seeing the chiropractor today. Said
Hmm.
the guy was spot on. Did a great job. So, and I spoke with Dan Gallo. Dan Gallo is CEO of a Mission Act Health Company, a for-profit,
Hmm.
and he's also CEO of the not-for-profit Navigator USA, and he's in talks with Dr. Harsfield and Dr. Lewis, and Ken Webb is the insurance guy, and they're trying to bypass all this crud and crap and create something on the side where they can help veterans. So they're going to try to squeeze me in somehow or another.
All right. Well,
They you've heard about the psilocybin and some of that stuff that's going on. They're bypassing it supposedly by using the Indian reservation centers to do the psilocybin on those reservations.
yeah, well, what's his name's been doing that for forever. Dan Royal.
Dan Roy, yeah, I mentioned his name. Well, hopefully we'll get him involved. See what we can pull off.
So, yeah, I'm not sure where. Apparently, I have two accounts in LinkedIn. She's got it in LinkedIn, and I got two accounts, and I'm in the wrong one. So
Really?
I can never figure these things out.
Yeah, I know it's kind of tough.
Okay, this is our speaker here.
Oh, nice, nice. Okay, got it.
So one of our speakers anyway.
Amen. I was in Grant Cardone's Growth Con. Remember, I went to the Growth Con last year in Vegas.
Yeah.
This year, I'm just doing it virtual.
Mhm.
I'm gonna stay out of trouble.
Okay. Hi, Miss Kennedy. Uh, nice to see you. Thank you for being with us.
That's right. I'm just going to call Ed and make sure he knows to jump on this Zoom.
No.
It's he just has to register, doesn't he? Like I did.
Where are you? You in New Zealand?
Yeah.
What time is it there?
It's 12:54
Uh,
Yeah.
in the afternoon.
in the afternoon. Oh, okay.
Wow.
All right. So at least we didn't get you up in the middle of the night.
No.
Okay. Unfortunately, we've had a little kerfuffle with the platforms the last few weeks, so we may have lost some of our audience. We were asked by A4M to join them, and they wanted us to use their platforms, and we used 2 weeks in a row. We had disaster. So this is our original.
Yeah.
So I hope we didn't lose too many folks, but I'm sure we lost some. So
Yeah. Hi, Ed. Oh, hey, I just sent you an email. If you go scroll to the bottom and click on the Zoom link, or click on them and then just register your name, Dr. Bill will let you in. Yeah, don't use the Google link, use the Zoom link, and it's in an email I just sent you. That's it. That's it. And go right to the bottom. And then you'll see a Zoom link. Okay. Bye. So Ed's coming on.
So Any particular way to introduce him at all? This other person here,
Well, I think
this is my right-hand man, Joel Peterson here, so.
hi, Joel. Nice to meet you. I
Likewise.
think I think what I'd do, Dr. Bill, is just introduce him as Dr. Well, you can introduce me and introduce him and let him talk a little bit about himself, and then you know, like you do, ask him about you know, how the story evolved, how he discovered Amerisate. I mean, it's a lovely story.
Okay. Yeah, we're doing good with it. In fact, I keep forgetting I need to order some more. So so we went through 2 cases since the last time I talked to you, which was what, not even 2 weeks ago. So
I'm going to let you into a little secret. Order now because my COO would kill me, but the price is going up on the 1st of May.
oh, okay. All right, there you go. All right, don't be too hard on us. We're burning it here. So
No, no, we're not. But we've got to pay for all of this science.
yeah, I know.
Just hideously expensive, but really good. I'm just checking to see if it's on. Has he registered with you?
Not yet. Let's see.
I'm not seeing
Yes,
any.
yeah, there he is.
There we go.
Is he on?
Yeah, he's on now. He's coming in now.
Yep.
Hi, Ed. Ed, you're on mute.
There we go. Yep.
Hi, Ed.
All right,
How's everyone?
thank you for being on with us. We're very excited. I know I'm excited because I told Sara my story with Calocurb, and it started out not so great, and then it had I told her it had a happy ending. So
Well, that's what we like to hear. Yeah.
so yeah, so I'll tell everybody, because one of the things that we I promised that as I shared it with Sara, was the program that I put together, you know, for myself and then my patients. So and so I'm going to share that with the group also, but we'll let you do, you know, we'll let you do your thing, and you be they hear me every week. So we've been doing this for since October of 2020. We've been here every Tuesday.
Wow.
Except one. I think it was one Tuesday was the 4th of July, which, you know, in the US is a holiday, and I decided I was going to take off. So other than that, we've been here every Tuesday, and we've had some of the big limelights of anti-aging medicine on. You know,
Wow.
you go to A4M, you go to you know, IFM, you go to pay a lot of money to hear those folks talk, and they'll come on here and they'll give us time. So
And now you'll hear Dr. Edward Walker.
yeah, so so I'm looking forward to it, because like I said, I'm all in with both feet. So, and
Awesome.
those of you who know me know that I'm like there used to be an old TV commercial way back when in the US called it was for Life Cereal, and the character was a kid named Mikey, and they used to say Mikey hates everything. So that would be me. So so I'm a believer. So
Oh.
and I've done really well with it, and our patients are doing great, and but you have to use it the right way. That was the key.
Yeah.
Well, Dr. Bill, I mean, Ed will talk more about it, but I love your one with the pickled ginger.
Okay, yeah, well, that's actually, we started using that. So we've been using the semaglutide compounded formulas for more than 2 years now. So we probably have over 1,000 patients on it, and we at first we did way better than the commercial products as far as side effects and equal or better weight loss with way less side effects and a third of the price. We had we put B6 in it and BPC 157. If you know what that is, it's a peptide. It's a GI peptide. It was actually discovered by Pavlov in 1904, and they were using it comes from the gastric juice of dogs, and they were using it as a sort of an antacid in Tsarist Russia, but he didn't know what it was. He also had discovered intrinsic factor, and he didn't know what that was either. He knew he had a protein and it did something with B12, but he didn't know what it was. So it kind of got forgotten until 1993, and then it kind of got synthesized. It's called body protection compound 157, and it has a GI. It has a GI component to it, and then there's an anti-inflammatory. We use it as an injectable, and we've done great with that. Also, we've had football players with torn tendons that didn't heal for 2 years. 3 injections and they're back playing. So usually we wait till 5-ish. Like I told Miss Kennedy, Dr. Walker, we've had a little kerfuffle with our platform the last 2 weeks, and we might have lost some of our audience because of it. But hopefully we'll have it back. If it's not too great a crowd, we'll make sure that once we rebuild, we'll get you on there. So it's a little after 5. Folks usually filter in. They'll keep coming until after 5:30, even later. So do you have PowerPoint or anything to screen share, or no? Or this is just a discussion I think we talked about, right?
Yeah, well, I can share the short one, Ed, and then you can talk through it like we've done before, and we can do can do questions and answers.
Okay. So welcome everybody. We're back on Zoom. We're back where we started from after 2 disastrous platforms, and thank you for coming back and hanging in there. Now I got to remember how to use this thing here. So we got to where's the record? Joe, you can see the record anywhere?
It says you're recording already.
I'm recording. Okay. All right. So thank you all for being here tonight, and welcome back to Zoom. This one I should be able to navigate without the glitches and all the issues that we had with the other 2 platforms. The one, by the way, just to let you know, is I actually had dropped something on the floor and bumped my keyboard, and it was 2 weeks ago, and it muted the speaker for like almost 10 minutes. So it was really, just ridiculous. Anyway, so we're back here. A4M is going to either like it or not, whatever. So, because I don't have the koyach, if you know what that means. I don't have the reserve to put up with that anymore. Anyway, we're really honored tonight. We have 2 folks with us. We have Sara Kennedy, who I've spoken to on a number of occasions, and Dr. Edward Walker. And Dr. Walker is the inventor of Calocurb. Do I have that right, sir? Is that how you would?
Exactly.
Yeah, so
I'll let Ed do it, but Ed is actually, he discovered Amerisate.
Okay.
He discovered Amerisate and he discovered it and developed it. So Amerisate is the active ingredient in Calocurb.
Okay. So we're going to explain what it is, what it does, and I'll tell you. I'm going to explain. We'll talk a little bit about my own personal experience with it. And it's why I'm so enthusiastic about it. I'll tell you what we did wrong, because I actually had it sitting on my desk here for over a year, and didn't touch it. And I just kept looking at it and say, oh, another weight loss thing that's a failure. I accumulate them like paper clips. But we were using it wrong, and when we got to learn how to use it the correct way, I think you'll all be really impressed with the results. So, Miss Kennedy is the CEO, right? Of I'm not sure what your company's name is. Is it Calocurb or is it something else?
Yeah, I'm the founder and the CEO of Calocurb, and
I'm going to let these folks. I'm going to let you introduce yourself a little bit better than I can, and tell the story, and we'll take it from there.
Right. So what I might do, Ed, is I'll share the screen, Ed, and Ed, you might want to introduce yourself and then I'll share the screen.
Sure. So I'm Dr. Edward Walker. I'm a research scientist. I work for the New Zealand government at Plant and Food Research, which is New Zealand's largest sort of government-owned research institute. And I also lecture at the University of Auckland on functional foods and nutraceuticals. And so basically the reason I'm here is that I developed a product, a nutraceutical-based product, which is being used as an appetite suppressant and also for weight loss applications, that's been commercialized and marketed as Calocurb.
So Ed, I'll share the screen if that's all right, Dr. Bill. So can everyone see that there?
We got it.
Okay. So Ed, I'll let you explain. And this is a whistle-stop tour of 14 years and 30 million of investment, mainly just about all in research. So Ed, I'll let you take it away. You can elaborate as much as you want because it's actually a wonderful story.
Right. So in 2010, Plant and Food Research got awarded a $20 million New Zealand, so it's about between 12 and 14 million dollars US grant to develop a plant-based nutraceutical for use in appetite control and weight management. And the reason for doing this is obviously that we've got a humongous issue with weight and the diseases that it can end up causing. At the time when we started this project back in 2010, there weren't really a lot of, I guess you'd say, good weight loss medications available. So you did have some. So you had the sibutramines and things like ribanicide, which are two drugs which have been removed from the market now due to side effects. And there was nothing, I guess, nothing that was highly effective and that also had a really good safety profile. So we decided to look at using plant-based compounds to suppress appetite. And one of the mechanisms we looked at was something called the bitter brake. And so this relies on essentially that your body is designed not to eat bitter foods, right? So if you think of, say, an apple tree, you have an apple tree, and what the apple tree does is it wants you to eat the apple, but it doesn't want you to eat the rest of the tree. So it makes the apple taste delicious, and it makes the rest of the tree taste terrible. Right? And so there's this sort of, I guess, what they call an anti-feedative system that's built into plants to stop, mammals from eating bits that they shouldn't. Now this is conserved, and it's in pretty much all animals. You can see it in things like cows and dogs and humans and monkeys. So all animals have this system. And we decided it would be really good if we could utilize this in order to suppress people's appetite. Now, the data supporting this is from that evolutionary standpoint of not eating the wrong parts of plants, as they might be toxic. But there's also evidence from various cultures that bitterness can control appetite and potentially lead to weight loss. So in the Highlands of Scotland, they used a bitter heath pea to suppress appetite during times of famine. It's used in bitterness is used in Vedic medicine, so in order to calm the gastrointestinal tract, improve diabetes, and lead to weight loss as well. And they also use it in the Kalahari, where Bushmen would eat a bitter cactus to suppress hunger during hunting trips. So there was this really nice evidence, sort of, I guess, which or traditional usage. Then around mid-2000s, we discovered that there may actually be bitter taste receptors in cells in the gut, and that these cells can potentially suppress appetite by releasing gut hormones to the brain. Now, one of these hormones is GLP-1, which is really popular now because obviously semaglutides are a synthetic version of GLP-1. Right? So we were looking into essentially something to trigger GLP-1 release well before the semaglutide craze hit. So in order to do this, in order to find a plant compound that may be able to stimulate gut hormones that release, that through targeting gastrointestinal bitterness and suppress appetite, we did a series of studies. First one we did was we went into hospital and got 28 people to give biopsy samples all along their gastrointestinal tract. So we said, okay, let's confirm that these bitter taste receptors are actually present all the way along the gut. And what we were able to show was we were able to show that of the 25 different bitter taste receptors people have on their tongue, everyone had 17 of those through every region of their gut. And some people had 24, maybe 25 of them through the gut. So the study was able to confirm that everyone had at least 17 of them. They were present there, and they were localized in regions where these gut appetite suppressing hormones are. The second piece of work we did was we took these cells from the gut, and then we grew them in the lab, these cells that have the bitter taste receptors and the appetite suppressing hormones, and we put them through high throughput screening. So it's the same as what drug discovery companies do when they're looking for something. And we put ended up being around 900 plant extracts and probably about 100 standardized bitter compounds. And we looked to see which of these would stimulate the release of compounds like GLP-1 from these cells, these gut cells. And what we were able to show was that, to be honest, the cells were pretty resistant. They didn't want to release GLP-1 unless you hit them with something really, really potent. We found a potato extract which worked, but when we identified the bioactive, it turned out to be toxic alkaloids that were a sort of a contamination in the skin. So that was no good. We had another couple of hits that were small peptide molecules, but they weren't stable. And so the only thing that really worked and that was likely to be stable was a hop extract. And so that's what we ended up taking forward. We then took that hop extract. Now it was quite a sort of a waxy, sort of thick compound or extract. And so we mixed it with a small amount of oil and ran it through some what you call simulated digestion models. So because this is a gut-targeted product, what you need it to go past the stomach into the small intestine and then disperse enough so that it can interact with the surface of the gut, but not so much that it just dilutes its concentration too much so it's not effective, or if you don't add any oil to it, it's so thick it will just pass through and not interact. So we optimized the formulation, we put it through some digestion models, showed that it would disperse about how we wanted, and then we were ready essentially to go into clinical studies. So we did 3 clinical studies to date on it. We can probably jump to the next slide, Sarah. So the first study was essentially the mode of action study. So in this one, what we wanted to do was say, okay, we have this hop extract. In the lab, it will make the cells from your gut release GLP-1. Can we do that in people? Right? So we got 20 sort of guys, and we gave them what we call a marasate. So that's the active ingredient in Calocurb, an hour before and eat till their full lunch. And then 2 hours later, they were given an eat till their full snack. So basically told, take the pill, wait an hour, here's a lunch, it's eat until you're comfortably full, wait 2 hours, here's a snack, eat till you're comfortably full. We measured how many calories they consumed, and we also took blood samples all the way through the study and looked at changes in GLP-1 and also another gut hormone which suppresses appetite, CCK. And we also measured PYY, which is sort of your third major appetite regulating gut hormone. What we were able to show, and if you see the top figure there, you can see that when people consumed GLP-1, when they consumed amarosate, their GLP-1 levels went down initially, and this is just a normal tracking down that you get over time. And then there's a response to lunch in the placebo group, so that's the bottom line, and that's exactly what you expect. Whenever you have a meal, these hormones are released to suppress your appetite, then it goes down, and then it goes up again for the snack, just like you would expect, and down again. With the amarosate, you see the top line, the response is increased. So you're still following this natural pattern, this natural up-down of GLP-1 that you get, but it's just boosted up. So overall, we're showing, it ends up being almost a doubling of overall GLP-1 response, and it's happening after the lunch. But what's really important here is that it's even more pronounced after the snack. So you're getting a long-lasting effect. So that response to the snack there is much greater in the in the amorosate treated group, and it lasts longer. It doesn't tail off quite so fast. And that's despite the fact that the participants ate less food. So they were eating less food, yet they were still getting more GLP-1 release. So at the lunch, there was a decrease, although not statistically significant. At the snack, there was a highly statistically significant decrease. And overall, between the lunch and the snack, there's about an 18% reduction. All right.
Sorry, do you want me to take the next one?
Yeah, we can go to the next one. So
Or
next we
are there any, I would just wonder if there's any questions on this one first, Ed.
Sure. So what I will say for this is we also showed a similar profile for CCK, which is a very potent appetite suppressor. We showed a small increase in PYY. PYY is quite hard to change because it's quite far down the gut. So that's again not unexpected that the change was smaller. We also showed improvements in postprandial glucose response. So the glucose was lower in the amorosate treated group, and despite the fact the insulin levels are also lower as well. And that's probably due to delays in gastric emptying that's occurring. So we had a really good spectrum of, I guess, biochemical changes that indicated improved glucose control, improved appetite control.
Right. Well, I'll just go on to the next slide for you, Ed.
Yeah. So
quick question on that one.
Yeah.
So when you use GLP-1s, you usually end up, my patients usually end up just eating one meal a day. So with the Calocurb, I noticed that the study actually has a lunch part and a snack part. So in this situation, Calocurb does not promote appetite suppression. It just is it just blunting the cravings?
Well, this is a model design system. So essentially the participants are forced or told to eat meals at these times. So they said, you're eating eat till you're full snack lunch here and eat till you're full snack here. Now in the snack, some of the participants ate nothing. So they were told to eat till they're full, and they just said, I'm still full from the lunch, so I don't want to have anything. But most of them had a little bit. So what it's doing is it's reducing how much food people eat, and it's doing that by stimulating endogenous GLP-1. We'll probably get more of an idea on the next slide with the next study, because this is very much I guess you call it a not real life kind of model. It's not how people eat. You don't have these prescribed meals that you're told you have to eat, even if you're not, really necessarily feeling like it. This is just to show that we're stimulating GLP-1. That's really the goal. And because we had that limitation in the study, the next study we did was an actual diet strategy people take. So we wanted to show can this product be used in an actual diet, and we chose fasting. And so this very much shows, does it change, your hunger? Does it change your fullness, independent of food intake? And when you're following a challenging model, right? So what we've done here is we've taken 30 men and we've asked them to fast for 24 hours without water only 24-hour fast, so no food at all. And we've measured them during the last 8 hours of that fast. So from hour 16 to hour 24. And the reason we've done this is because that's the time when you typically get a whole lot of hunger increases, and you're really starting to get to the top end of your hunger, and it becomes very hard to stay on the fast. We gave them a amorosate or Calocurb pill at 16 hours into the fast, and then also at 20 hours into the fast, and we asked them to record their changes in hunger over that period of time. So this is asking a question: how hungry are you? And not at all, or as hungry as I've ever been. And so what you see is you get in the placebo group, which is the bottom line, is the top line, you get an increase, and then the sudden jump at about 100 and what? So the sudden jump represents the lunchtime. So that's an increase in hunger you tend to get at mealtime. And then the increase continues over time. With the Calocurb treatment, you can see that mealtime hunger increase is very much blunted. and the overall increase in hunger is quite a lot less. So it's about a 20% overall increase in hunger it's been decreased by, or an 80% reduction in increased hunger. So that's the change over that period of time. Now, this is, hugely significant. So anything over about a 10% change is likely to be perceivable to the participant and result in a real world ability to change behavior. So we showed this, and this was really great because this is, I guess, a challenging diet strategy people use, and we were able to show decreases in hunger. We could also show favorable changes in fullness as well. So the next study, Sarah, we essentially did the same thing, but in females. And this is one of these interesting things where people ask, they say, well, why have you done the research in males and not in females? And the reason is because of menstrual cycle, and it causes a whole lot of complications with the study. So this was done in healthy women, and they had to be synced to both the day of the week they were doing the fasting. So if they did it on a Monday, they had to do it on a Monday the next time, and a Monday the next time as well. And they also had to be synced to time and menstrual cycle, because menstrual cycle has a big effect on your food cravings and your hunger. And so that made the study, quite difficult to do, but we thought it was very important because females are typically not studied for this reason. And we really wanted to show that the product was effective in the female population. So again, same design, we recruited 30 healthy females and put them through a 24-hour water-only fast. We gave them, again, the Calocurb capsule was given at 16 hours and then again at 20 hours into the fast. And we measured hunger and fullness, and we also measured food craving in this study. So we asked people, are they craving for food or not? And we thought this was quite important because one of the reports you get is that women suffer from food craving a lot. And it's not so much necessarily hunger that's driving them, it's a craving for a particular type of food. And so what we were able to show this was really quite remarkable. It's very interesting. If you look at the hunger profile, which is down the bottom, you can see that the Calocurb treatment effectively flattened the hunger on those last 8 hours of the 24-hour fast in the females. So they were no more hungry at 24 hours than they were at 16 hours. And when you compare that to the placebo group, you can see the placebo group had an increase, sort of a gentle increase and an increase at lunchtime, flattened off an increase when you normally have a slack, and then they flatten off. And at the end, they're pretty much as hungry as they can really ever get. Now, this was really interesting because this data is way nicer than the data you get in the males. And the reason for this is because the female participants fill in the questionnaires way better. The males just brush through it really quickly and they make mistakes. The females don't make any mistakes at all, and you get beautiful data from them. Now, what got Sara probably the most excited was this measure here, which is craving for food. And so we actually drove the craving for food down. So the participants were craving for food less at 24 hours than they were at 16 hours, and that compares to the placebo up the top, where they had about a 20% increase in craving for food. So we're actually making them crave food less. Now, we got a really interesting result here. And again, anything over about a 10% change here is perceivable to the participant and likely to result in behavioral change. Now, we also measured craving for sweet foods or sugary foods. We don't have the figure here, but it was changed, but only at the post-meal point. So we gave a eat till you're full meal at the end of the 24-hour fast. And the participants ate about 14% less. So again, that was in line with what we saw in the last study and is really, really good because it shows they're acting on their decreased hunger and decreased craving. But after that meal, their craving for sugary food was quite a lot less when they'd had the Calocurb treatment. And when you think about people wanting to have dessert after a meal, if your craving for sugary food after a meal is reduced, that means you're more likely to say, no, I don't want dessert. Because of the way we did the stats on the study, it technically doesn't come up as significant because we have to take the entire period of time. We didn't do a slice analysis, and that's to do with what you put in the ethics when you start. But if you look at the figures, it's really promising there. So that's our third study. So that's next slide, Sarah.
Right. Just does anyone want to ask any questions before I move on? These are the 3 published clinicals that Ed has gone over.
Yeah, I would like to know what the average diet is in New Zealand. We're kind of big here in America, going between vegan, vegetarian, carnivore, keto. What do you guys mostly eat over there?
Yeah, it's an interesting one. I mean, we have a quite a similar diet to the Americans. Yeah, so we if you look at the dietary studies that are done, New Zealand, Australia, and America are reasonably similar. We end up with the same kind of split, where you have people who say, some people say vegan's the way to go, some people say only eat meat. We get the full spectrum of that. So it's, you know, it's sort of, I guess it's sort of similar to America, really.
So you didn't ask anybody to alter their diet to a specific set of factors in response to
No,
what they're doing? You just let them go?
just let them go, yeah.
Right, I'll just move on to the next one. Ed, I'm sorry, he always gets grumpy with me because I haven't corrected the top line.
All right. So it's not a crossover study. It's a parallel study. So we've got a weight loss study, which which we're undertaking now. And so it's 150 men and women where we change the BMI. So 75 in each group, 75 on Calocurb, 75 on a placebo control. They're getting diet and exercise advice from a dietitian, and they're being given Calocurb at the recommended dosage, so the daily usage. 6 months duration, with a 3-month follow-up. We changed, so the BMI is now 25 to 35, so we lowered it, we altered that BMI range a little bit. And it's had provisional ethical approval, and we're going back for some changes right now. We're also doing a series of emotional eating questionnaires that are being taken during the study. So I guess one of the things is we can do all the weight loss measurements, we can do a DEXA scan, start and end. But what we want to capture is we want to capture people's, I guess, weight loss journey, and how Calocurb can be used to change that, to change how they're feeling, their relationship with food is, whether they're getting the same urge to emotionally eat, whether they're getting the same cravings for food in general. So we have a whole series of questionnaires going on along there, and then we're just, primary outcome is body mass. We're also doing body composition changes as well. So yeah, so that's the way shortly.
Yeah, we start that very well as soon as it comes out of ethics. Basically, our ethics don't seem to have the same urgency as we have, but that will come out. That will be done by Plant and Food Research, which is the government the largest government research institute. So just here, I can talk to this fairly quickly, just so everyone's aware. It is a patented formulation. Our patent has been granted in the US. It comes from a specific variety of New Zealand hops, which are grown, actually, I don't know if you can see my little pointer, but it's grown in the top of the South Island in a place called Motueka, which is one of the most beautiful places in New Zealand. It is GRAS approved, and it's used using freshly picked hops that are then extracted by supercritical CO2 extraction. It takes out all organic matter and the phytoestrogens, just leaving the alpha and beta acids and a small amount of essential acids. Essential oils. We then ship this to the US, where it's made in another patented delayed release LICAT. So a delayed release LICAT, which is manufactured by Capsugel, which is a Lonza company in Greenwood, USA. That has GMP, TGA, NFS, and FDA approved. We then bottle and label in the US if it's for the US, and we distribute in the US. So you see there, we're manufactured and distributed in the US, but it does use New Zealand, it does use our Amerisate hops very small amount of rosemary extract, and which is really a preservative, and a vegetable oil, which, as Ed said, helps it distribute in the gut. Just how people are using it in the market, and then I'll hand it over to you, Dr. Bill, is people are using it, practitioners are using it as people come off the injectables. So, you know, we hypothesize that when you're using the injectables, you're most likely reducing or flattening down your endogenous release or your normal release of these appetite suppressions, because you're putting in a supraphysiological amount of injectables. So they're using it as people come off, and we're getting fantastic response to that, to allow them just to reinvigorate, I suppose, or to reconnect that brain-gut access.
Yeah,
or they're using it as an
we're using it. We're using it always. So we're using it as a part of our standalone. I told you I paired it with another product, and I'll explain that to the group, and towards the end. We use it as maintenance. So when they come off of the injectables, and again, as I explained, we use a compounded product, and we've altered it somewhat. So we've added some the antiemetic agents to it, and we get much less side effects that way. Or if they come in and they're on the commercial product, we use that either as an adjunct or again as sort of a maintenance type program. So we found it very versatile and able to use it quite nicely with really. Somebody asked about side effects there. A little bit of nausea, maybe if you overeat, but that's about it, and certainly nothing like you get with the with the injectables at all. I haven't had anybody say they couldn't take it, at all so far. And
yeah, and I think, as we've said there, it's either as they come off or as an alternative. If people can't take the side effects, if people don't want to inject themselves,
and the expense too, and it's expensive too. So.
And a cost base.
Right.
Sorry.
And the Calocurb is 1/10 the price of the semaglutide or the tirzepatide. So it's really, in comparison, it's really quite affordable. In our hands, the way we use it now, it quite frankly, I mean, I hate to say it, it's almost foolproof if you use it properly. And like I told you when we first talked, I was using it wrong, and I put it aside and said, this, here it is again, and here's another one that doesn't work. I was introduced it to at A4M, I think in December of 22. I think you guys were there then.
Yep. Oh no, 23 actually.
Well, I think I've got, or how about AMMG? Were you at AMMG in Florida?
Yeah.
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 Okay. So that's where I got it. So I got one bottle. I tried it, and didn't like it at all. Didn't do anything for me. I got another one in the mail, and like I said, it sat on my desk for almost a whole year. And then everybody in our group knows our old friend Jay Campbell all of a sudden started singing its praises. And if you click on one of his videos, you can't avoid him. He's just all over the, I think he's in the last 2 days, he's made 27 TikTok videos. I just started counting. I don't watch them. I just count them. So, so I called him and I said, Jay, use this stuff. And he asked me how I used it. And when I told him, he says, you're doing it all wrong. And then so he straightened me out, and I'm going to let you finish. And at the end, I promised everybody I'm going to give them my protocol. So I don't want to take your time. So, and like I said,
That's great. There are a couple of questions here. One from Anna is what kind of contraindications from taking Calocurb? And I suppose we say there, if you've got any sort of inflammatory gut disease like Crohn's or something like that, we would not take it. Ed, do you want to add anything to that?
Yeah, so I think that's, I mean, if you've had some sort of bowel resectioning, then I'd suggest that I mean, it's not that you can't take it, it's just that it may require some more optimization of dosage and protocols because your gut emptying is different. You may end up delivering it to a slightly different place in the gut, which will alter bioefficacy. So yeah, so I guess if you've got someone who's had gut resectioning done, particularly things like a bypass surgery, you might find that they've got different sensitivities to what other patients have. So that's a point to consider rather than a contraindication. But there's probably not a lot. I mean, I'm a scientist, not a medical doctor, but we are targeting the gut. So there's not a lot of systemic absorption of this product, so it's primarily broken down in the colon. So there's less concerns around interactions with drugs than most other products.
Yeah, it's sort of got a 24-hour life. It was, almost 99% degraded in the colon and less than 1% in the bloodstream. So very, very gut focused. Laura has asked, is this free of gluten? Yes, it is gluten-free. It's vegetarian and gluten-free.
And not tested on animals.
And not tested
Unless
on
you count
animals.
students as being animals.
And not tested. I think Dr. Stephen did ask, how does Amerisate differ in the length and effect versus the prescription GLP-1s?
Right, yeah.
And I think you might have shown that, Ed, but you might want to talk to that.
Yeah. So I can cover it. I mean, so a little bit about GLP-1 is GLP-1 is this gut hormone that suppresses appetite, enhances glucose control. Now in the body, GLP-1's half-life is 2 minutes. So basically your gut has to be releasing it all the time. And as soon as it stops releasing it, the GLP-1 levels just crash down. So what they did when they made semaglutide was they got the GLP-1 protein, it's a small peptide protein, and they modified a couple of positions, and that stopped your body from being able to cut the GLP-1 in half and make it non-active. So the semaglutide's half-life is a week or 7 days, and natural GLP-1 is 2 minutes. So they're fundamentally different. What we do is we boost up your body's natural response and make your body release GLP-1 for a little bit longer. So it really does. So if you think about your natural GLP-1 response to a meal, it's up, it's down, it's up, it's down. With the Calocurb or Amerisate, it's up a bit higher and it just tails a little bit longer, then it goes up a bit. So we're just boosting up your physiological response, but it's the same sort of profile. So you're not going to have GLP-1 active at night. We're talking maybe 4+ hours. I mean, some people will get an entire day from one treatment. It is a bit variable. But you're not going to have GLP-1 being secreted when you're asleep at night. And that's very different from those semaglutides. So if you think about a semaglutide, GLP-1 from semaglutides is high in the morning, it's high in the evening, it's high when you're asleep, and that's the time when you normally have zero GLP-1. It's high the next day, it's still high. So it's very different in the profile of activity.
Thanks, Ed. Just one here from Anna is this product an immunostimulator?
Right, so we don't have any data to indicate that it's immunostimulator. We may take some immune measures during the weight loss study. We're still working that out. What I would say is right now we don't know. We don't think so. But if it was an immune stimulator, it would only be gut immunity that it would be affecting. So there wouldn't be a general central immunity stimulation.
Just the other question here, is it on full script? Yes, it is on full script. We were rushed through full script late last year, and they're now selling from it. Dr. Stevens asked, I don't think we know this, Ed, is there a way to break down the GLP-1 peptide, that must be the injectable, the synthetic, to clear this quicker? We wouldn't know. We wouldn't be able to answer that, would we, Ed?
I mean, no, I don't believe so. I mean, they fundamentally designed it for stability, and I think when it was interesting, really, because when they started designing these peptides, they had various levels of stability. So some of them were, and they're even on the market now, daily doses, and some of them have shorter stability lives. But really it became a marketing choice for them, saying, how often do you want someone to inject themselves? And so they decided a weekly injection was probably doable for some people. So they chose that stability. There's not really, I mean, I can't see any way of breaking it down faster. It doesn't have any, the semaglutides don't have specificity for your endogenous enzymes. And it's got high plasma binding. So yeah, you're sort of stuck with it once it's there.
Got a question. What about youth studies and or youth recommendations? We got a pretty big problem here in America with our youth being overweight. What's the lowest age you recommend could be used?
Yeah, so again, I'm not a medical doctor, and I can't make medical suggestions. However, from a science standpoint, what we know from the work is that, or from bitterness in general, is that females and children are more sensitive to bitterness. So we would expect, or adolescents, so we would, and we see that in the male versus the female study, we see the females are more responsive. So we'd expect children and adolescents to be more responsive to the product if it was given to them. There's no scientific reason they can't take it. But again, we haven't done any trials, and I mean, I'm not a doctor, so I can't, in theory, recommend it. Yeah.
I can say for Ed that a lot of practitioners are using it. You know, and the fact that a semaglutide is approved for anyone over 13, they are using it because they're finding a lot less, they'd rather use something natural to start with, and a lot less stigma around for children with injectables. But, you know, we don't go in competition to injectables. You know, I think it's absolutely amazing the fact that, you know, it has opened up this discussion about obesity and the physiology of obesity, you know, which I just absolutely welcome. So we're just saying we are an alternative, we're in a natural alternative. But yeah, many practitioners are telling us that's how they're using it. Melvin's asked, what is the average weight loss in a week? Well, Melvin, we'll actually be able to tell you that categorically after our trial, which starts hopefully very soon, and it will take 18 months. But, you know, what we would say, and we need to do some modelling, is if you're getting an average of an 18% reduction from 2 main meals, so, that's around about 400 calories. So you are reducing, but we need to do some modelling on what would that mean for weight loss. Anecdotally, we get fantastic responses back from people, how it's really helping them. We do absolutely like selling through practitioners because, as we say, we're only one tool in the toolkit. We are not, you know, we're not the magic one. And, you know, it needs to be with good behavioral changes and diet changes. You know, if you go from 10 donuts to 8 donuts, you may not see too much. So yeah, so behavioral and diet changes with it. Bill's asked, do you see any accommodation after prolonged use? Well, you can ask that. I can certainly tell it from an anecdotal, but you can talk to.
So we wouldn't expect it to. So one of the reasons for choosing this mechanism, well, there are 2 main reasons. One is that this bitter response mechanism is very fundamental to the body. It's a strong food aversion signal, and it's conserved through you know, multiple species. It's not just for humans, and it's not something that your body doesn't suddenly decide, I want to stop avoiding toxins, basically. And so we're basically tricking the body into thinking it's had a toxin when it hasn't, and that's what's telling you to stop eating. As far as the other point, with GLP-1, again, we wouldn't expect a physiological type profile of GLP-1 release to be to lose its efficacy, and the reason for that is because you get GLP-1 every time you have a meal. Right, and people suddenly don't start, over the course of their lives, suddenly don't start going, oh, well, GLP-1 stopped working. It continues to work the whole time. So both the hormone-based mechanism is not something that you get, you know, accustomed to, and the physiological triggering the bitter system is not something that's likely to develop any sort of resistance.
The reason I ask
And
is because
sorry, Bill.
our proprietary GLP-1 program, we do see some accommodation, so we have to stop it periodically and you give the patient breaks. So that's what the
Yeah,
injection.
well, I wouldn't be surprised. I mean, I think that when you look at giving essentially what's a exogenous hormone at a very high concentration that's not following physiological profiles, then you get that. I mean, and the classic case study is anabolic steroid abuse. And, you know, people who take anabolic steroids, they take big doses and injections, their endogenous shuts down completely. And then over time, they become used to it and they become dependent.
Okay.
So just on that, Bill, well, you know, I've been on it. I've been on Calocurb for 5 years, almost 6 years now, ever since we first made. I absolutely, it's fantastic for me. I use it, well, I use it daily, and I intermittent fast daily. So that, and we have many people who have been on it for as long as it's been on the market and literally just swear by it.
Would you recommend increasing the number of pills if you're having a bad day or a bad week, or it's, you know,
Absolutely. We do say to people, you know, like some people only need one. That's why we start off on that onboarding dosage of 1 pill a day for 2 days. And they're fine on one. You know, and we're not quite sure why. We talk to Ed about it. Is it because they have more receptors? Is it their physiology? Or something like that. For the majority of people, it's 2, you know, an hour and a half before a main meal, if that's how you're using it. And for some people, it's 3. So I think it is one of those ones that you can adapt to your physiology. But we do, it's sort of like at 5% at one end, a 1, 5% at the other end, a 3, but that 95% or 90% a 2.
Yeah. So I can comment a little bit on this. And so we targeted the gut, and the great thing about targeting the gut is that it's got a good safety profile. You don't have to get it absorbed into the body. You can get these wonderful appetite regulating hormones. But if you're targeting the gut surface, the downside is that you're not effectively concentrating into a relatively fixed volume of blood in people, which means you're very dependent on how has the pill got to the right part of the gut when it's released, and how is it dispersing in their upper intestine. And so there's more variation is basically what that causes. And because there's more variation between people, the dosages is a little bit harder to get. And that's why Sara says, you know, it's better to increase over time. And it's also really good to have people involved in the process of prescribing the product who understand that, you know, the gut's a little bit more variable than if we were giving a pill that was, you know, a central effect, and that, you know, you might require some optimization. You might require some optimization around pill treatment versus meal timing.
So our friend Jay Campbell is doing an every other day fast as we speak, and on his fast days, he says he's using 6 of them. So
yeah. He's a powerhouse, that man.
But you know, he's a little. If you know what a Meshuggah is, you know, he's a little bit of that. So okay. There's some.
I mean, it's not going to do, Bill. It's not going to do any harm. It's just, you know, we're going to, and that comes on to Laura's question. I saw some reviews that mention abdominal pain or diarrhea. You know, I think abdominal pain, we rarely ever get this. Probably more, I think, as Dr. Bill said, maybe a little bit of nausea if you overeat. Re-diarrhea or flushing, in around 5% of people, when they first start taking it, they will see a flushing effect. That will go over, you know, 48 hours. It's just the body getting used to sort of that increased release of GLP-1. It's quite natural, and we say to people, you know, it's good in a way because it says your body is really responding, but we're very, very upfront about it, and that's why we have that slower onboarding, you know, 1 a day for 2 days. Ed, have you got any comments to that?
Just that, I mean, so Sarah covered it mostly, but when you got any biological effect, you always got an associated side effect. And for us, with the GLP-1 type hormones, the CCKs, the effect is this: that's no effect, appetite suppression, and then at a higher concentration, potentially gastrointestinal flushing, and then maybe even higher, some nausea type effect. And so what we're getting is we're just saying that, that person is just a bit more sensitive. So if you can lower it down a bit, then you should be able to get that appetite suppression without any of the associated side effects. But if anyone tells you there's a product out there that has all these wonderful effects and you can't take too much and there's no side effects, then that's they're not telling the truth.
Our experience is if they overeat, they eat through, with what, their fullness from that's left from the GLP-1, and it happens with the injectables too. Or they're eating junk food. If they're going to Popeye's fried chicken and having ice cream and pizza, they're going to be sick. There's just no way around it. That seems to be the sort of the two pitfalls.
It's quite interesting. It seems to be high fat. It does. We've had a bit of feedback on that.
So GLP-1s were first, developed or found to lower blood sugar and to improve hemoglobin A1C. Have you looked at that at all as far as what you have available going on?
So data-wise, all we have is acute improvements in postprandial glucose levels. For the weight loss trial we're undertaking, we will be looking at changes in HbA1c as well. And so although it won't be a diabetic population, I'd still expect that they will be the high end of non-diabetic, and we'd likely expect some improvements in that as well.
Okay, so then my next question was, and you probably don't have an answer to this one either, is have you looked at the effect of using Calocurb, sort of the end effects on the microbiome?
No, so we haven't looked at effects on the microbiome as of yet. It is something we would consider. It is a bit, the microbiome is a tricky one. So because it's so different between people, there's a lot of variation in microbiome between people, but it's certainly on the list of things to do.
All right. So for instance, so we see a lot of immune thyroid disease, and tied in with that is a lot of GI dysbiosis. We do our microbiome tests and we see parasites and fungal infections and disruption of a normal flora, normal bacteria. Would that be a place where we have to be cautious as far as using something like Calocurb?
Yeah, I mean that's a good question. I mean it's not likely to be an issue as far as bioactivity of the product goes. Right. However, I mean, if someone's going to suffer if they're going to get a flushing effect, then there's obviously, if they've got pre-existing gut issues or parasitical infections and etc., that might be a consideration. To be honest, it's something that we'd be really interested in looking at, I think, to see what the effects were. There's also the potential that it may help with gut issues. So no good answer at the moment, but we'll put it on the list of to do.
I gave you a few already today, right?
Yeah. Well, all I need is the funding.
All right. So
if it didn't cost so much, we and our ethics committee didn't take so long, we'd be peering through them.
Yeah.
Okay. So in case you're, folks in the audience don't know, GLP-1s actually aren't all that new. I mean, they're fairly new, but they aren't all that new. I mean, the first one came out in 2005. And the most famous of all is Januvia, from Merck's Januvia. Have you looked at the effects of Calocurb versus the oral the oral pharmaceutical drugs at all?
No, we haven't done those studies. Again, that would be great studies to do,
Hey,
but
put it
yeah,
on the list.
it's on the list. Yeah, I could do with a research intern if you're keen.
You know, if I didn't like this stuff and I felt it didn't work, I wouldn't be bothering you like this, you know?
Yeah.
Just- you know, I don't mean to monopolize everybody's time here. Somebody else ask some questions here.
Oh, Edward, Sarah, that was a great presentation. So, as you can see now, GLP-1 activation is kind of like the hype of any type of supplement, just because of the rise of semaglutide, Ozempic, tirzepatide, and now recently new products are coming out, such as a probiotic named Akkermansia, was actually enhancing the L-type production of GLP-1. And we also have berberine as one of nature's Ozempic, as we call it. What are other synergistic supplements that you can recommend that we can use when you're using Calocurb?
Yeah. So
Well,
I mean,
they're all different. Sorry, go ahead, Ed.
well, I was going to say with the Akkermansia, that's certainly an interesting one, and I'd be very interested to see what the combination of that with Calocurb would be, because essentially so in your body you tend to have if you've got more L-type cells, or if it's increasing the number or the potency of the L-type cells, and then we're stimulating them to release their GLP-1, then of course that's going to be very beneficial. As far as most things on the market go, there's not a lot that has really good, as far as GLP-1 release, clinical data. And when they do show changes in GLP-1, they tend to be really small. So like, sort of maybe a 10% change or something like that. Whereas we're getting very high changes around, almost a doubling of release. So I'm not sure there's a lot of products you'd combine. Have you got any ideas, Sarah?
Well, berberine, they work by different mechanisms. Berberine works in the cell, and it balances the blood sugar, but it doesn't do anything to GLP-1. Nothing at all. There's nothing on it. Akkermansia, I think, it takes 12 weeks to work, theoretically, and it improves the mucosa, as I understand, of the gastrointestinal tract, which then promotes GLP-1. But it's never, they haven't measured the GLP-1 increase. So, I think if it's promoting a good microbiome, I think that's fantastic, but it takes 12 weeks. We take an hour. So it's like comparing apples and oranges. So berberine, yeah, but it's a blood sugar. Akkermansia, yep, as a microbiome, as a probiotic. Yeah, but we work in an hour.
Yeah, and so when they advertise berberine, they do say people do say nature's GLP-1, but really most of the data is around AMPK regulation, so it's more like nature's metformin.
Yeah, and they just use Ozempic because it's a buzzword, but as Ed said, it's more nature. So I think, and that's not being cocky, we are patented, and that patent has taken 6 years to be granted in the US. So you have to be completely novel and new science to be patented. So we don't, our nearest competitor, or we would like to say, aside from that, is not a competitor, but like us, as the injectables. And I think, the first one being Ozempic or Wegovy is just GLP-1. Tirzepatide is GIP and GLP-1. You're kind of getting the three with us. We're getting, CCK, GLP-1, and PYY. So you kind of got the treble dosage with Calocurb.
I'm sure you've heard of Retatitude, though. That's supposed to be coming out next year, and that's a GLP-1. Was it GID? Is that the second one? I forget. And it has I'll have to look it up. It's got a third ingredient in it. So it's allegedly more effective and less toxic than the other two.
Yeah. Well, we do think a combination. Sorry.
Attitude, I think.
Well, I think that's one of the strengths that we get with Amarosate or Calocurb, is that because we're triggering not just GLP-1 but also CCK and also PYY, that we're able to hit that appetite suppression level for 3 different hormones rather than having to push one very high. And so that gives you better bioefficacy with a lower side effect profile. And that's certainly what they're seeing with the drugs, which target more of these receptors at a, arguably at a lesser amount.
So, with some of our audience here, when I'm just kind of looking at them. So Carol Peterson's here. She's our hormone expert. So we need studies on what it does to testosterone and estrogen and the DHEA. We got a lot of work to do here. So,
you wouldn't think, Ed, that it would do a lot to those hormones because it is just gut focused.
Yeah, wouldn't expect changes, but you never know.
Yeah. So, okay. And, so what is your current recommendation for, using Calocurb?
Well, we try to keep it really simple. It does depend on what people are doing and what you want to do with your patients. We keep it quite, simple. We say take 2 capsules. Well, you obviously have your onboarding, but take 2 capsules an hour to an hour and a half before lunch and an hour and a half before dinner if you're looking to reduce your portion sizes. I mean, I intermittent fast, I do 16-8, so I take mine at 9 o'clock in the morning. But if you want to reduce meals, take it an hour to an hour and a half before the main meal.
Okay, so there's 90 pills in a bottle. If we do four pills,
it's almost a month's supply.
Yeah.
Why we say it's not quite a month's supply is because, the great thing about Calocurb is, if someone's going out for a really nice dinner, they may not want to curb their appetite. They may want to, not curb their appetite over the weekend or something like that. So almost always, it's more than enough, the 90 caps.
Well, I told when we talked before, I told you, one of the great things that I loved about it was, I had a 0 birthday right in the middle of all that I was using it, and I went on a cruise, and I actually was a pound lower than when I got home than when I left. And I used this, and we ate. We ate. I didn't really skimp on anything, but I didn't nearly eat as much as I normally do.
You just can't.
My lady friend did not, and she gained 5 pounds, and she's still mad at me. It's a month later. So
Can you overdo this if people just get so excited about losing weight? Do you have any experience people doing too much?
So I can comment, I guess, on if you overdose, then what will happen is you will likely get gastrointestinal side effects. As far as because your body can only produce so much GLP-1, you can't, you've only got so much you can release from your cells. So if you start taking more and more of the supplement, it's not going to continuously increase GLP-1. It's going to hit a level and stop. So in some ways, there's almost a built-in safety profile there that you can't overdose your GLP-1. And if you take too many of the pills, you'll just get a gastrointestinal, probably a flushing effect.
Okay. All right, Dr. Quinn, you got anything for us tonight? So
Yeah, I got one ridiculous question. Is there any kind of interaction or activity enhancement or whatever with leptin? Does this affect leptin in any way, or are they completely separate mechanisms that cause the brain to think you're full?
Yeah, so these effects are typically independent of leptin effects. What I will say is that there is evidence that some of these hormones may have increased efficacies if you also have changes in leptin along with them, but leptin changes are certainly not required for bioefficacy, and we don't see them in treatment.
Okay, and then as far as the GLP-1 agonists in general, it's slows gastric emptying and all that. Can you tell me about the effect on insulin and insulin release and glucagon and all of that?
Right. So we actually will. So what we've seen in the at least the acute studies is that because we're getting quite a delay in gastric emptying, what we're seeing is we're seeing decreases in postprandial glucose levels, so post-meal glucose, and we're also seeing decreases in insulin as well. And that's likely because there's just literally the food is being delayed. Yeah.
Okay, no, that's great because I think as we know that if insulin is increased, and that kind of makes the body hide, shall we say, hide leptin. So this is not increasing the insulin release.
No, if anything, it's decreasing insulin release because of the gastric emptying delay. Yeah.
Okay, okay, great, thank you. Good.
Have you found any specific dietary plans that work better with the Calocurb than others? Have you looked at that yet or no?
We haven't looked, but we chose fasting because fasting was, I guess, a really good, a really compatible diet system. Because your gut is very empty, so it's quite easy to deliver the capsule to the right part of the gut and get the hormone stimulated. But Sara might have more comments on what's come through from the consumers.
Yeah, it really depends on, I think that's the value of it as well. It's really, we are just helping people to eat less and they can eat the diet, which is, and I think Ed is always like that, not to try and put people on a diet per se, but just to reduce the amount. And I think also taking that craving, and let's call it that hangry, away, people can make healthier choices because they're just not like, give me food and give it to me now. So yeah, we don't try and we prescribe healthy eating, I suppose. So less processed food, just healthy eating, I suppose.
Okay. One of the big complaints out there in the internet land is that with the injectable GLPs, you get some physiologic changes that are sort of untoward or unwanted. Now there's some ridiculous things like you've heard of Ozempic face and Ozempic finger, and if you lose weight, you're gonna your face is gonna be thinner. But the one complaint is a muscle loss of muscle tissue. And do you have anything on that at all?
So again, we'll have data on that with the weight loss trial. We're hopeful that we won't have too much loss in muscle mass. I mean, it does occur. What I will say is because we're following more physiological patterns and we're allowing the body to reset at nighttime, we're hopeful that we'll have, I guess, less of those wasting issues that you see. I do believe Sarah's had some people who've done, there was a doctor who did DEXA scans when he was losing weight?
William, I can send you on a video from him. He was amazing. We met him at Terry. We met him at OMA. And, very most doctors do use themselves as a guinea pig to start with. He didn't believe in supplements, didn't believe in that, but said, well, I'll try it. And lost 60 pounds, but did it in a very methodical way. Did a DEXA scan before he started it, did all of that. And at the next OMA, or obesity medicine, that we went to, he came up and he was just over the moon, and he said, I've lost 60 pounds, no muscle mass. It's the only thing that's ever worked for me. So anecdotally, no, we don't see muscle waste. And I think Ed said, it's because it is following the physiological patterns of the body.
Okay, good. Okay.
I have patients who are having problems taking capsules. Would it be a problem if they open up the capsule and maybe put it in liquid or in a carrier?
It would be a massive problem. It is extremely, extremely bitter. So I wouldn't advise that at all, and that's why we put it in these. And the way it's formulated is to dissolve in your upper duodenum. What I would say, Melvin, is these are pretty small capsules. They're 125. They're 125 mg. They're tiny capsules, so most people are fine on them. I haven't got. I can show you one here if you want, but they're little wee tiny ones.
There
Yeah,
you go.
unfortunately, the capsule is really required for the bioefficacy. And if you take it out of the capsule, as Sarah said, it will taste terribly bitter, and it's not just
There you go.
not just acutely bitter, but it's also persistent. So if you put it on your tongue, the bitterness will last for hours. And it will also prevent it from, obviously, if it's out of the capsule, it won't get to the right part of the gut, and that will again limit bioefficacy.
Okay, great.
The interesting thing is, just very quickly, we are doing with Ed involved too, but with another government agency here. We got a $500,000 grant of turning a marisate into a food ingredient that we would be able to put in with, like a protein powder, which would not only give you the satiety of the protein, but it would prolong it. So we've just gone through the first, well, we have made it into a stabilized ingredient, which is microencapsulated. We're now going through biodigestibility trials, but we are still probably 2 to 3 years off it, because we would have to then do cellular ones, and then in vivo. But that's what we are working on. So it could be added as a food ingredient.
Oh,
Would that be bitter if that's going to be added in a protein drink?
No, because it's microencapsulated, and it's done in such a way, like the institute we're doing it with are experts in microencapsulation. So in these tiny beaded, and what they've done is encapsulated, so it passes down from the stomach into the upper duodenum. So the protein theoretically will stay in the stomach and curd in the stomach. So we're actually doing that. We're actually doing some of that work with Fonterra, which is the sixth largest dairy company in the world here in New Zealand. And so it's quite exciting work, but it's not. It won't be soon. But we're excited about it.
When I was looking for some pictures for the email, to send out, there's a couple there. It looked like you had some in a powder form or some sort of it didn't look like a bottle like we get it. It looked like it was almost looked like in a thing that we get coffee in, like ground coffee. Is that another form of it, or is that just somebody mock something up?
Would have been mocking it up. No, it would have been mocking it up. The extract itself is like a very, very thick paste, as Ed said, and it's very, very stable. The other thing about it is it's incredibly stable.
Mm-hmm.
For our international practitioners, is there a way that they can access this?
Yeah, sure. It can either contact us directly, and we can ship it to the country directly. Like we have, we sell at the moment in New Zealand, Australia, America, and China, and we actually sell into Puerto Rico. So if there is someone in a country who wants to bring it in, we usually try and help them with it.
Okay.
It depends on the regulatory environment of the country as well.
Okay, so Dr. Nario is from the Philippines, so I think that's what he was alluding to.
Okay, fascinating. Yeah, I'd love to talk to you about the Philippines. I am just not sure of your regulatory environment in the Philippines.
Yeah, well, I know, as I went there and actually met up with a contingent of integrative practitioners, and Metagenics is there, Douglas is already there, Orthomolecular. So there are other supplement companies already in the market. So I'm assuming there is a way for you guys to get in there. I just don't know what the specifics about it, though.
Yeah, no, there certainly will be. We just have to look at the regulatory environment. And, it depends on the regulatory environment. If you take it in and make no claims and you go through a practitioner, hops have been used for 1,000 years. So, it's a very, very safe ingredient.
Well, it's just unfortunate. Why I brought that up is because, of course, as we become Americanized as well in the Philippines, definitely weight is becoming an issue. So US problems are other countries' problems as well.
Malaysia is the same. Malaysia is identical. So, you know, I mean, America tends to beat itself up, but I tell you what, everyone's racing up pretty fast behind.
We have more business for you guys. That's a good thing, right?
Yeah, we hope so. But we love it. As I said, I will reiterate, we do like going through practitioners because we are just one tool in the toolkit.
Mhm. So, and that brings up the next question: is what about supply? Is it readily available, or is there shortages?
No, there isn't. Those that could kill me at the moment, we did run into a shortage in February. There is absolutely not a shortage of the ingredient. It was just a hiccup in our bottling and labeling, and that that's over now. And so no, there won't be going forward. Well, unless it just goes completely. It's not the supply. It's just the supply chain, if that makes sense.
Yeah, well, we all have that issue. So,
but certainly not like it's certainly not a like the trizepatide or anything like that. I mean, they actually have a supply issue. We don't have a supply issue. We have a supply chain just pushing it through. Actually, it's just been at our bottlers and labelers to tell you the truth. It's them. It's not even the capsules. I just want to hand up fistfuls of capsules, but unfortunately, I have to go through the next stage.
so
I was talking to Dr. Bill this morning about oral semaglutide now being available. I think he knows about it even before. I just found out about it. So we are really, I know patients will be cautious about increasing that dose. Can you think this can be in conjunction be used with oral semaglutide, or is that going to be too much for them?
And what do you say, Ed? We kind of say that it's sort of a bit of an overdose. What do you think?
Yeah,
Ed?
well, it's a tricky one, and again, I have to play I'm a scientist, not a medical doctor card, but we stimulate three hormones, so CCK, GLP-1, and PYY. If you're taking a therapeutic dose of a GLP-1, then you're unlikely to get any benefit from the GLP-1 release that occurs from Calocurb. The only thing is you may be able to maintain your body's natural release profile, so you may be able to that may be a benefit, but you're unlikely to get any more appetite suppression. You may get some effects from CCK, and you may get some effects from PYY. So I mean, it's not a hard no that you couldn't do it, but we don't have any data to support it, and we know that where one of the three hormones is probably not going to be doing anything in that situation. So I mean, if you want to try it, you can try it and give feedback. Yeah.
Well, Jay Campbell is using it as microdosing on a semaglutide or trizepatide and using Calocurb at their home time. But we can only give you anecdotal of that, but they're using a much lower dose and then using Calocurb at the same time.
Yeah, because there's a concept also about this. Actually was from the Seeds camp, William Seeds, about doing microdosing of semaglutide rather than following the regular dosing, but they're actually focusing more of the other effects other than losing weight, so for brain enhancement, cardiac enhancement. So I have seen this, and I have seen practitioners and patients do this. So they're not following the recommended dosing. So I guess that's right. It's remained to be seen, I guess.
okay. So Dr. Quinn asked about the contact information. Could you type it in the chat? And I have Sarah's contact information, and I have your the website, what, calocurb.com?
Yeah, well, no, for practitioners, go to the wholesale site, wholesale.com, and just register on it. It's not a hard thing there, and just register on it. www.wholesale.com, and then you buy it wholesale, and the I've forgotten what the price is, but it's a terrible thing to say, isn't it? But it has the MR.
I paid $38.49 a bottle.
That's right, and its recommended retail or MSRP is $69.99.
I've seen it for 62 and I've seen it for 277.
No.
Yeah, somebody, I think it was for 2 bottles, $277.
Oh, no. Well, someone's price gouging then, and it's not us.
Well, I mean, it's right next to it is three. One said 69, one said 69.99, one said 62, and then one said 277. So I
Wow.
don't think they got too many sales out of it. So
No, no. So I've just put my contact address there as well.
okay, and I have your contact also. So you have any any sort of a summary wrap up? I promised to give my protocol, so I'd like to do that before we say goodnight. It's getting to be on, especially on the East Coast here. It's almost 9:30. Well, okay, here in Reno, it's only 6:30. So,
Dr. Bill, I just wanted to thank everyone. Thank you, and Joel who assisted you, and thank you for I would say this is 14 years of Ed's life. He said he didn't have grey hair when he started, and 30 million to date. I think the other thing is we only focus on one product. We only have one product, and that's what we use. So, and we're not branching out. We literally focus on that, and we love, as you can imagine, talking to people about it.
Yeah. So, and we appreciate you both being here, Dr. Walker and Ms. Kennedy. It's an honor really for us to have you with us. Like I like to say that, if we ask you, if you do a good job, we'll keep bothering you to come back. And if you don't do a good job, you won't hear from us again. So I only get asked to paint a house once. I never get asked the second time. So, so there's that. So, any Dr. Walker, anything from you? So like I said, I promised the group that I would share my protocol. It's a little bit different than what you have, because I added a second product, and I'll when I go through it, I'll tell you why. And we tried a lot of them. We tried about 7 or 8 different sort of Kickstarter programs. And I came down with one where we actually had a better weight loss than all of the others. So I'm going to talk about that. It's my show, so I can say. I was going to say if that's okay with you, but it's my show, so I can do that.
We might drop off because I know Ed's got a meeting, and I've got a meeting, but I'll drop off. But
well, that's fine. Thank you. So we'll be in touch. Thank you so much, really, for being here and for enlightening us. And I'm sure everybody that's still on here has found it quite interesting. I mean, this is you can call tomorrow morning and have the stuff delivered by the end of the week and get started. That's kind of what we like to do. The theory's great, and we talked to Dr. Halasa's not on tonight. We talking about Clotho and all sorts of crazy things that they talk about, but how practical is some of this? I mean, this is the real deal. So we can't thank you enough. Thank you for your dedication. 14 years is a long time to be spending one product.
It takes time to do scientific research properly, and that's the key. Yeah.
Okay. You look like you've weathered it well. You look pretty well, pretty fit there. You don't have any gray hair. It's like at least
I've got gray hair just the light.
where you are. So right, and not too many wrinkles. You're looking pretty good there.
Yeah, it's all the Calocurb. It keeps you young.
I know. Well,
Ed.
Okay. Dr. Burgess, you got anything? He's our other right-hand man. So you got any questions?
No, you guys are the masters of the trade and a league above me. But this is all absolutely fascinating stuff. My little thing with Ozempic almost wiped me out. And now I'm hearing your methods and I'm wondering, dare I try it? And I think I will, but I think Ozempic was way, way, way overplayed, had side effects people don't talk about. and your methods make absolute rational sense. So thanks for sharing all of that.
So, you notice my two compadres there have something in common.
I can see that.
Exceedingly impressive beards, yes.
Yeah, and ZZ Top is coming to Reno at the end of the month, so I think we're going to all have to go there. So,
I love it.
okay, thank you so much. If you want to stick around, I'm not going to take a whole lot of time, but what I'm going to do is share the screen here, and this is my program. We came up with it. Like I said, we have been doing the injectable GLP-1 since December of 2021, actually, more than 2 years. We were really successful with it. We had put in, we were using 1.25 milligrams of semaglutide and 1.25 milligrams of BPC 157. If anybody doesn't know what that is, I'll explain what that is. And 40 milligrams of vitamin B6. So B6 is used in OBGYN now, especially for morning sickness. BPC 157 is a antiemetic, and it was, I guess, like I said, it was discovered by Pavlov in 1904. It was purified in 1993. And in 2023, the FDA came around that decided that all of a sudden it was no good, and they made the compounding pharmacies take it out. So we were kind of left a little bit stuck. We did a 5-night-a-week 0. Like microdose, 0.2 cc's injectable. So the patients got 1.25 milligrams of semaglutide in a 5-day period, but over 7 days. And we had very good success rate. We had a discontinuation rate of about 3%, which is way better, much better than the commercial products. I think Ozempic is official discontinuation rate is 44%. It may have changed, but that was the last I saw. Ours was less than 3%. Then they made us take out the BPC 157. And when we did that, I was really kind of concerned that we were going to have, a jump in our again in our discontinuation rate. One of the two of the advantages of the way we were doing it. One was that we had very little comparatively low side effect discontinuation rate, and the cost was about 1/3 of that of the commercial products. So I'm not sure where it came. It's been probably close to a year, but it came to me. I don't know. It was sort of like a dream or something. But I started recommending fresh ginger, pickled ginger, like you get in a Japanese restaurant, and the real thing, not tea, not pills. Somebody tried ginger beer. That didn't work. And that took our discontinuation rate now that I know of in the last 8 months, and we're seeing anywhere from 4 to 8 patients a day, either online or in the office, with some sort of GLP, mostly injectable still, but we're transitioning over now. We've had 4 patients in 8 months discontinue, so 1 every 2 months. We have over 1,000 patients in our program total, and in the last 8 to 9 months, we've had 4 discontinuations. What we did with them, I'll just give you a little hint. We used something called MOTS-C, which is another peptide. We gave that as an injectable, and that did okay. So like I alluded to, my experience with Calocurb was I got it, I guess it was about a year ago in April. Then if you guys weren't at A4M in December of 2022, it would have been in Miami in April. And I took it sort of like it said on the bottle. I took 1 a day for a couple of days, and then I took 2 a day. I think that's what it says on the bottle. And I really didn't get anywhere. I took 1 when I got up in the morning, and I took 1 when I went to bed at night. And that, and after a while, I said, well, this isn't really doing anything. And I put it aside. I got I got a free sample from somewhere along the line. And like I said, it sat on my desk here for about a year. And then we were looking for, so what happens with our injectable 5-day-a-week microdose semaglutide is you can become accommodated to it. We didn't know that. I was my first guinea pig. I lost 22 pounds in 6 weeks when I first started using the injectables. And I took it for 4 months straight. I did it every day. And then I stopped after you get to a set point, and I was at that pretty much at the same weight, and nothing, there was nothing changing. And after about probably a month, but it was about 4 months in, so I stopped using it. And things started to gain it back a little bit. And, you go to parties. It was the summertime. Joel and I have to go on our road trips to give our talks. So it started coming back. I started using the semaglutide again, the way we had. Nothing. It felt nothing. We had gotten terzipatide by then, also nothing. So I was casting about and saying what else is available, and I really got nowhere. I actually gained all of the weight back that I had lost by January of this year, and that's when Jay Campbell did his little thing. He does his TikToks and whatnot, and he says this is the best thing going. And like I said, I called him and I said, Jay, I use this stuff. We gave it to a couple patients. We had it. It didn't do anything. And what he told me is that we were using it wrong. And you heard tonight how it is. It should be used. It should be used an hour to an hour and a half before each meal. And we like it. We like to use it if you're doing 3 meals a day. I usually tell my patients, you can see it here. These are the exact instructions that we email. This is a Google Drive file. These are the exact instructions. Day 1, and day 2, we tell them to take 1 around 10 o'clock in the morning just to get used to it. From day 3 on, we have them use 2 at between 10 and 11 a.m. and at between 4 and 5 p.m. If they're doing intermittent fasting and they're eating twice a day, we have them use it again 2 hours before their first meal, 2 hours before their second meal. If they're fasting, we usually have them use either 2 or 3, and that'll keep the hunger down. So that's how we use it. But I was still having some problems or issues in the morning. So we have a lot of products around, and we've tried a whole bunch of them. There's one here from the nitrous oxide guys called, I don't know if you can see this. It's called Hunger GLP. It's a powder, and it's got chromium in it and some amino acid complex, and it tastes a little lemony, and it pretty much didn't do anything. We've used this one called AMPK. It's got gynostemma in it, which is a Chinese herb, which is an AMPK metabolic activator. It's a fat burner, basically. It's got some hepcidin in it. We use this, and it was sort of neutral. It really wasn't negative or positive. So we have a lot of orthomolecular products, and I had gotten this one called high phenolic, and this has magnesium in it, lemon, verbena, hibiscus flower, and green coffee bean extract. And I started using this one, 2 of them in the morning, first thing in the morning when I get up, and that turned it on. So that did the trick. When we ran out of this and I went back to the other ones, we were flatline as far as weight loss. Now I'd already lost quite a bit of weight, so I've lost 17 pounds since January 20th. Pretty much at the set point now. I keep it off. I use the 2 Calocurb-Ths, as you see here, 2 around between 10 and 11 and 2 between 4 and 5. I use the 2 high phenolics in the morning on an empty stomach. For a sweet tooth killer, because those of you who know me, I was born into that. We use some apple cider vinegar. We use 2 tablespoons and 6 ounces of water. I did listen to just this weekend to a weight loss summit by an outfit called the American Academy of Functional Medicine, and they were recommending plain, not combined Gymnea sylvestri, which we've used for blood sugar control. I think 400 milligrams. So we may try that out. to kill the sweet tooth. But we do pretty well with the apple cider vinegar. You have to tell the patients to be a little bit careful, though. There's a lot of apple cider vinegars now they've been flavored. There's honey flavored and orange flavored, and we tell them that kind of defeats the purpose. So we recommend fresh ginger. It acts on serotonin, the brain receptors. It's anti-inflammatory. It reduces intestinal distress. This absolutely works. And anybody who's when we do the injectables, we tell them to have the fresh ginger and chew on it, a piece of it when they're taking the shot, and if they get any nausea. This was the key. And so we do this even now. Quite frankly, if there were some nausea and side effects from even the Calocurb, I really don't know about it. We do have a ginger spray that was made again by the same company that makes one of the nitrous oxides. So this is sort of a summary of what Hyphenolic does. You use 2 of these on an empty stomach as soon as you wake up in the morning. The 2 Calocurbs around 10 to 11, 2 at between 4 and 5. We do encourage some exercise, high intensity interval training, and we have a lot of people that don't do exercise at all, and they're not going to go to a gym. So I went on YouTube and I found a whole bunch of old videos from back in the late 80s and early 90s. We all paid a lot of money for these things: 8-minute abs, buns of steel. Richard Simmons, there's a 13-minute sweating to the oldies. They're kind of campy, but the exercises are fun, and they're okay. I mean, they're okay especially for somebody who's been deconditioned, has been doing nothing. I myself do the 8-minute abs every day, and then one of the others first thing in the morning when I get up. I don't always want to do it, but I do it. I kind of push through. So that's sort of the plan. So again, 2 Hyphenolics first thing in the morning on an empty stomach. The Calocurbs, as I told you, fresh ginger, make sure you have that on hand. I've never had to use Pepto for anything. I've never had any issues with this. We make sure that the patients drink, because they're going to be eating usually less than half of what they normally eat. We don't want them to get dehydrated. So we usually say 6 to 8-ounce glasses of water. One of them should have a pinch of Himalayan or sea salt in it. Find some activity. When we did the HCG diets, we told them not to have any activity. We do the opposite. We want you to be active. We want you to do your activities. Let me blow this up just a little bit here, a little bit better. Okay. And then those of you who remember last summer, we talked about Body Sight. That's an online program, and I'll pull that up before we go. We use this as our diet plan. They actually have a GLP-1 semaglutide. It's made for that. It's an automatic online program. You type the patient's name and email address in. It sends an email to them. They have to respond yes, and then it'll automatically send them menus, recipes, shopping lists every day for 70 days. You can tack on an extra one. So for 90 days, they'll get recipes, menus, shopping list. There's also exercise plans in there with videos. It costs $199 a month. I mean, it's pretty, and it's got every other diet, and you don't need it just for that. It's got every other diet plan you can think of. It's got keto diets, Mediterranean diets, paleo diets. It's got the intermittent fasting, AIP, the autoimmune. And I'll show you that before we go. So the side effects that we're talking about here. I got these actually from the Ozempic semaglutide, and on the injectable one, I actually have the percentage, and it's not from us. It's the percentage from the drug company itself. So nausea with semaglutide is 44% of the patients. And again, the key here, make sure they get the ginger, no junk food, and they have to limit their portion size. They have to, don't overeat. When your brain tells you you're done, and that seems to be the key. If necessary, over the counter, they can use some Pepto-Bismol. We also like zinc carnosine or a deglycerinated licorice. You can get those. We get those from Orthomolecular. You can still get oral BPC from the peptide companies. and oral B6. So we have those on hand. If it's bad enough, they need prescription. I think I've written one prescription for Zofran in the last year on our program. So very little. Diarrhea, again, increase fiber, hydrate, and you can use Imodium if you want. I think we've had one patient that I could think of that complained of diarrhea. Vomiting, I've not had anybody. We like L-glutamine, the deglycerinated licorice, and zinc carnitine and aloe vera. This comes together. Orthomolecular has a great product called GlutaShield. It has all of these products in it. It's a powder, and if you get the chocolate, it actually tastes good. Also the BPC 157. If they're really ill, if you have the injectable, you can actually give them an injection, either sub-Q in the abdomen or in the arm, and vitamin B6. For constipation, again, increase high fiber foods. Again, magnesium will help. Cod liver oil. You can do a cod liver oil pack and just have them hold it against their abdomen. And then this is an old, I learned this in my acupuncture school. This is an old Chinese remedy. Whole fat yogurt, plain, with 9 raisins, and the master, said you have to count them out, not 8, not 10, it has to be 9. And it's still around. They recommended brown cow. So this was an old Chinese master in downtown Philadelphia, probably 1982, told me this. So we've used this from time to time, and this is a bit of a help. Abdominal pain, and again, this is from the Ozempic and tirzepatide. You need to rule out pancreatitis. The castor oil packs, Epsom salt baths, licorice root, again, deglycerinated licorice. It has activity against ulcers, particularly H. pylori. Black cumin for abdominal pain or even gas and diarrhea. Basil leaf, ginger again. There's our ginger again, and mastic gum. And you can get combinations of this. Apex Energetics makes a combination, has all of these in it. So any one of those. Headaches, again, these are the side effects that are from the semaglutide, Ozempic package insert. Headaches, make sure you check their blood sugars. They should be gluten-free. Increase fluids. Peppermint or lavender oil. You can, for headaches, we've used arnica, we use homeopathic remedies or feverfew. Again, vitamins B1 and B6. The patients come in the office, we do the ear acupuncture for them. The headaches usually are gone within 5 minutes. Fatigue, make sure, again, gluten-free. We have to always be, aware of something, a leaky gut type regimen. D-ribose is a good for energy, magnesium and potassium, and of course stress reduction techniques. We use berberine and resveratrol for maintenance. We tell the patients we don't expect you to lose weight with using these, but when you're done, this will help keep it off. It's a fairly high dose of berberine, 400 milligrams, 2 in the AM, 2 in the PM. We like Numedica for this. Again, it has, gynostemma in it, which is an AMPK modifier. It increases energy expenditure in it. So we like that brand. It's not that expensive. And then resveratrol. And full disclosure, I write articles for a company that makes resveratrol, 50 to 100 milligrams. So there's 2 types of resveratrol. There's a cis and a trans. Most of the products out there are the cis resveratrol. You need the trans. Cis resveratrol is 5% active. The trans resveratrol is 95% active. So since we're not CME, the company that I write for is called Longevinex. They have 2 products. One's called Longevinex and one is called Longevinex activator. It's a little bit more potent. So resveratrol has actually about 50 different positive properties as an anti-inflammatory, increases energy expenditure, it reduces cravings, it reduces body fat. Like I said, when we use these 2 in combination, it does not. We've not seen a real weight loss. Usually we save this for maintenance, and the patients can stay on this for a very long time. I searched around for when all of a sudden with the GLP-1s, the injectables, all the crazy complaints, where you can look up the New York Post. A side effect of Ozempic is Ozempic finger. So, you lose the patient that were losing weight and their fingers got thinner and their rings fell off. So that's a first world problem. So, and then muscle loss. I personally have not seen it. Stefan, if you're still on, I know you do more with fitness people and weight builders. You may see it more than I would. So we use creatine. We'll do one to 3 scoops a day. You have to watch out. Will raise testosterone levels. It will increase oily skin, and patients will get some acne. So that's my program. If you want to look at, I know it's getting late. Real quick, I should have put this up beforehand. The body site. And if you go on aosrd.org last summer, we actually had a talk about this program from the company. I've had this for 10 years now. I was one of their first people that I signed on. And they have all of these plans, and there's more, and you can write your own. In fact, I have written my own. I have this one here, thyroid enhancement. This is for patients with thyroid disease. I wrote this myself. They'll give you a blank slate, and you can write in your own. And what'll happen is, so they have they have a diabetes prevention program. This is the semaglutide weight loss, so it'll give you kind of an overview. It runs for 10 weeks, and this is what the patient will get. They'll get an email every day. This is the first day, and it will give them a little overview of what semaglutide is. I haven't sort of altered it yet for Calocurb, but when I get a chance, I will. They'll tell them what's good to eat, what's not good to eat, and this is sort of a paleo keto type diet. It'll give you a checklist of things to do: drink water, make sure you do your injection. There's videos in here. This is how to do the injection, how do they work, and it'll give you recipes. It'll give you a breakfast, lunch, and dinner. When the patients sign up, they make an account, and they can look at how much fiber they're taking in for the day, or how much sugar, or how much cholesterol. It's pretty much endless. I'm not all that interested in that. If they don't like what's there to eat, you can go to pretty much any other day. This will always be at the top, and you can go here. And we include this with our program, but if you want, and you can do it separately, you can actually sell it. You can actually list it for sale. You can put it on your website and sell. By the way, I don't work for Calocurb. They don't pay me anything, and I don't work for Body Site. They don't pay me anything. So I'm not, I'm not making any money off of any of this stuff. I just wanted you to have, this is what I do. This is what we've been successful with. So that's kind of a brief overview. Does anybody have any questions about it? That's what we do. Any questions? I see we lost 10 people while I was talking. So
your patients,
it wasn't that exciting.
I didn't realize that. So your patients have access to Body Site?
We assign them the Body Site. So
Okay.
we assign them. You saw there were lots of different plans there. There's a paleo plan. There's a keto plan. They can put in their own recipes if they want. You can write your own. There's Mediterranean. You name it. There's the DASH diet is in there. There's an intermittent fasting program in there. You name it. It's there. It shows up. The way it's programmed, it shows up at 3:01 a.m. So it's there for them in the morning. And I don't know anybody who follows it, to a T, but it's actually a good way for us to say, well, you're not teaching them anything. Well, yes, we are, and it's continuous, and it's there all the time. And they can access it once they sign up. They can the programs that they get assigned to, they can access them forever and a day. Okay. And for us, I don't have to, we have a dietitian that we can refer people to, but we've pretty much cut out that need. It costs us $199 a month. I mean, it's pretty, it pays for itself in 30 seconds. So Okay, and
Turbo,
again,
can you sneak
I
in
don't-
the
I don't get any money. I don't work for them. They don't even know I'm talking about this tonight.
Turbo, can you sneak in the high phenolic with the intake of the Calocurb? So at least you can, as you know, patients, if they take more frequencies with a supplement, the compliance will be less. Can
Right.
you just sneak it in there?
What do you mean?
Meaning you're taking 10 a.m. and 2 p.m., two Calocurbs, right?
Mhm.
Can you just split the dose of your high phenolic, one each, so at least you can have twice a day, or have you done
Yeah,
it?
you can, I guess. I don't know what's going to happen. We're going to get a few of your people to do that. So, like I said, this really, if you wake up, if you're like me and I'm always, I have to eat something right away. The high phenolic really slows that down. So, and I get to the point where I don't have to. I do my exercises. I do a lot of writing in the morning, and then I eat, half of what I used to. Okay. In the office, and because you're with me on Tuesdays, so Dr. Nario was away for a couple of weeks. He's been back. You remember I used to sit here and eat the stuff out, right? All day long, right? You've been here back 2 weeks. I don't even have anything here, right? That doesn't even bother me.
I know. Well, you can save more money now.
Yeah. Yeah. So any questions on that? I'm more than happy to answer it. If not, I know it's getting late, especially on the East Coast. On Friday, the BioQuantum Academy is having a homeopathic conference online. If anybody's interested in it, I can get you the link to that. I am speaking on it, and I'm stepping way out of my comfort zone. I'm doing the introduction to bioidentical hormones, the homeopathic version. So I'm only discussing homeopathic remedies for manipulating hormones. No hormones at all. No pharmaceutical medications. No prescription medications. So I don't know. I'm not sure how it's going to go. My knowledge of homeopathic remedies has increased greatly in the last couple of weeks, but I'm a little bit nervous because Dr. Zarin's been doing homeopathy for 40 years, and I hope I don't get exposed. But so like I said, I'm stepping way out of my comfort zone here, and we'll if you can't make it, I'll let you know how it goes. I'm on at 1:30 Eastern on Friday. So I got a half hour to make a fool of myself. So next week, by the way, at Age Management Medical Group in Miami, and I'll be there. I'll be doing 3 lectures. I'm doing an introduction to male hormone optimization, and I've added a little extra there. Carol, you'll be happy to hear this. So usually introduction to male hormone optimization, we talk first and exclusively about testosterone, and I've thrown a curveball in. So we're going to start with progesterone for men. So it's again, it may be the last time they ask me to come visit also. I didn't quite get my iodine talking points down. I've been picking Stefan. Is he still on? I've been picking Stefan's brain. He's leaving for Italy, I think, shortly. I thought he was going to be today, but he was on tonight. So so that's next week. If anybody's in the Miami area, it's at the Doral National. And it's always a good conference. It's not anything like A4M. It's not, over the top, so many people, you kind of get lost. It's a good group. And usually half the group is always newcomers, new practitioners. So it's always fun, breaking in a new recruit. So that's coming up in the end of this week and the next week for us. Anybody else have anything going on? Any announcements or anything? So, so I hope it went.
Yeah, I have a question.
Today, other than those awful platforms that we were on. And
looks like Shell.
I just
Yeah, I have a
I just
question.
told the A4M people, I can't deal with this. So
I know. No, I don't blame you. I have a question. My question is, like, what about like in the yoga naturopathy world, I heard that one day you do a juice fast, like you do half a day with vegetable juices and half a day with fruit juices, and you give your system a rest. That's one thing I heard. And then
Yeah.
they talk about gallbladder flushes or liver flushes, and
Yeah,
it's very interesting.
I'd have to defer to somebody else on that. I don't have any, I don't really know a whole lot
I
about
mean,
that.
that's like old stuff,
Mhm. So I don't know, Dr. Robin, is that up your, do you do kind of those kinds of things?
I don't really, I'm sorry.
Okay,
No,
all right.
Well, just thought I'd ask.
Yeah. Okay. I'm sure we got somebody that knows about that stuff. We'll hunt them down.
I can refer Dr. Dr. Morsi. He's the fruitopian. He's the fruit guy. He's cured a lot of people's cancers with fruit. And you got Yaki Awaken. He was a gang banger out of St. Louis who became a biochemist. And I've never heard anybody explain anatomy as I've heard Yaki Awaken. And he uses fruits and vegetables for detox like nothing I've ever seen. It's absolutely
organic.
Yeah. Oh yeah. Of course. Anything organic as much as possible. But I haven't really heard about going back and forth between fruit and vegetables. That's kind of like a neat idea, to be honest. And I'll do the best I can to research more and let you know.
And Sergio Girasunis has written books on juices and diets, and I have to look them up. But I remember he spent quite a bit of time on that.
And we just had a big event here in Reno, and Neil Bernard was the keynote speaker, and I missed his speech. I think Dr. Nerio got to hear it. That's up based off his new book. He's the plant-based guru, and how we're all going back and forth between the meat eaters and the plant-based. And I just really think it depends on your metabolism. And your culture and your situation and where you're at in life and the sicknesses you have and the autoimmunes that you have and blah, 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 blah. So it's just, I'm diving deep into that as much as I can.
Cool.
Okay.
I'll keep up with
Thank you.
So,
yeah.
Okay. So I want to thank, there was a new name on here. It looks like she just clicked off. No, she's still there. Faye Lynn, thank you for being here. That's a new name. I hope this was interesting. And thank you for being here. We're here every Tuesday night, 8 p.m. Eastern, 5 p.m. Pacific. We've been here since October of 2022, and we'll be here next week. So John, any last, or is John still on? No, John's off.
I'm on.
Okay.
There's a bunch of
any last words?
More and more really, really good stuff is coming up.
Mhm.
And it seems like this organization is going to be key to getting naturopathy and integrated medicine not just on the map, but maybe restructuring the osteopathic profession.
Well,
So I was giving, I went to a psychic.
Don't get my blood broiling.
Let me make it simple for
It's
you.
a 4-letter word in my life.
I went to a psychic chiropractor today, and at the end of our meeting, and he didn't know anything about my personal past. Anyway, at the end of the meeting, he says, "Can we have a word of God? Would you mind that?" And I said, "Sure." And this guy comes up with everything right smack dab on the money. And he started to cry. And he said that we are going to be able to bring naturopathic medicine back into osteopathy. And I had no discussion with him about this at all. He was talking like a psychic. But anyway, after he said that, I was uplifted, and I was thinking we have quite a duty between us few people who are here. We're going to make changes.
So what you're telling me is we should re-enter the fold?
No, man. I think we can do just exactly what we're doing now, and things will work out for the better.
So
Okay.
John, some good news for you. The Homeopathic Board of Nevada is starting to open up our bylaws to naturopathic doctors. in relation to opening up their practice here in Nevada and giving them more leeway from it. Because the board of naturopathy, I think, was lost for almost more than 10 years here. So as we open up more opportunities for them to be providers and of our same wavelength. So that's something that we're actually spearheading right now as we speak.
The need is great.
And this gives all the other states a leeway into how to deal with this. It'll be powerful. It could spread rapidly, especially if we get the veterans involved and we get a lot of the doctors that are involved with Dr. Halassa, Dr. Farshine, Dr. Lewis, Dr. Harsfield, Dr. Carter, and then they're involved with a whole bunch of other people. So we're all trying to work. Well, we're not trying. We're working on this, and we're getting some big players involved, and we're getting insurance involved, so we can bypass actual big pharma and use our own insurance companies to deal with this, to get this type of community care to our community. So don't give up. We got this.
Yeah, I always told the I have a big chiropractic following, and I always told them early on, said, because they were always lobbying to get Blue Cross and insurance payments. I said, you might get what you wish for, but you're going to regret it, and now they do. So. So that's the second insurance. That's the second 4-letter word after the O word. So, all right. Anybody have anything else? Comments, questions? So since we're back on Zoom, it takes a little longer to get the Zoom video rendered, but I'll have it up either later tonight or off later tonight or tomorrow. So it may take up 48 hours to get it up on our website, and also that YouTube channel that seems to be mushrooming with my name on it. So it's Clearfield Medical Clinic, Clearfield Medical Group on YouTube. All the videos sort of get there. AOSRD.org has the videos. .org/webinars has all the videos. I know it's not very user friendly. There's a lot of videos on there, but if you do a Control F or an Open Apple F and type in a name or word, you'll get it. If you want to watch that body site, the whole video on that, we have about we did a whole night on it. If you want to see how it works but the body site people, I think it was last July. So if you type in body site, do that, you'll find it there. Okay. I hope this was better than the last 2 weeks. It did go smoother. And we had a pretty good crowd for our usual. I was really fearful we would lose at least half our crowd because of the technical difficulties, but we had 33, I think, here, so that's okay. Bring one person and we'll double our census. Okay. Okay, John, what did you do here? He's been. Oh, okay. I have to do it.
It doesn't work.
So you're drawing pictures again?
Well, for Easter, I made
Yeah.
turned you into Jesus and wrote certain things about it. But I don't see it coming up, so don't worry about it.
It ended up in my computer download, so it didn't come up on the screen. So.
All right, thank you, everybody.
Okay, thank you. We'll talk again. We'll see you soon. Thank you all for being here. And Fay Lynn, whoever you are, thank you for being here. Say hello, and if it's okay, if we can put you on our mailing list, we'd be honored. So, okay. Good night, everybody.